Thank you so much. I just want to make sure everybody knows that was not me kiteboarding in the beginning of the video. I wish it were. I'm a pretty average snowboarder, but I haven't gotten around to kiteboarding yet. But thank you so much for that fantastic introduction. I think we just need to get the slides up, and I probably need to share my screen.
That would be great.
There we go.
They look great. Thank you.
And let's see. Am I in slideshow?
Oh, actually,
I think,
not
are
yet.
we all set?
John, are you in? Is she in slideshow?
Dr. Chutkan, if you want, can you end the slides and then end the slide
reopen them? Sure. Yeah. So stop sharing.
Yeah. Oh no.
And close the slides and then reopen.
Yeah. Yeah.
Okay. Okay, and then share again.
That's correct.
Wouldn't be a good conference without some technical challenges. Okay,
now it's great.
How are we there? Great?
We're good. Yep.
Fantastic. Great. Wonderful. Well, first of all, welcome everyone. This is really just such an incredible conference. I was looking at the schedule yesterday and it was so great to see some familiar names and faces and some other people who I've admired for a long time but never met. So I know I'm in great company with all the other speakers and with all of you. So I'm going to go ahead and get started. My talk today is about creating an antiviral gut, which quite frankly is the same thing as creating an anti-inflammatory gut, which is the same thing as creating an anti-cancer gut, because the common factors that lead to an increase in viral infection also lead to an increase in inflammation, in cancer, in autoimmune diseases, et cetera. And by the end of our time together, you'll be very aware of what those factors are. So let's dig right in. I'm going to talk first about the microbiome with some basic definitions. I think you guys are very sophisticated about this, particularly if you've been listening to most of the lectures, but I still want to make sure that I'm defining things for people who may be a little less familiar. I'm going to define a very important term called dysbiosis, which, as you'll see, is at the heart of all of these conditions. Then we're going to spend some time talking about the immune system and specifically the gut-immune connection. We're going to discuss a couple important clinical studies, talk about inflammatory bowel diseases, and then take a brief look at my data from the Digestive Center for Wellness. And then finally, the question that you all want answered, what to eat. All right, let's dig in. This is one of my favorite quotes from Hippocrates. You're probably familiar with his quotation, all disease begins in the gut. But this one, it's more important to know what sort of person has a disease than to know what sort of disease a person has. So this really speaks to this idea of a root cause for many of these diseases. And as you'll see, a lot of that root cause is coming from the gut. So when we think about biome, what we're talking about are the trillions of organisms that live in and on our bodies, mostly in our gastrointestinal tract. We can't see them, but if we scrape them all up, they would weigh about 3 to 4 pounds. We're talking about 100 trillion microbes in the human body, and actually more than 1 billion in one drop of fluid from your colon alone. We have about 23,000 human genes and about 3.3 million genes. And in fact, our microbial cells outnumber our human cells 10 to 1. So we really are more microbe than human when you think about it. In terms of what our microbes do, so obviously making smelly gas, right? That's certainly one of the roles. Our microbes in the process of digestion, we have some byproducts, hydrogen, methane, et cetera. So smelly gas is part of the equation. And smelly gas is not always bad. Remember, if you're eating a lot of high fiber foods, cruciferous vegetables, you are often going to make gas. And I'm going to tell you why a little later in my talk today. But so in addition to the central and important role of digestion, our microbes are also involved in synthesizing vitamins. And I want to give you an interesting example of that. When you're admitted to the hospital with an infection, you're often given a broad spectrum antibiotic. And what that means is an antibiotic that is active against a wide array of bacteria. So when you come in, the medical staff may not be sure what specific organism you're growing in your, if it's a bladder infection or whatever it is, pneumonia. So they give you a broad spectrum, powerful antibiotic that kills off a lot of your bacteria. Well, after about 3 or 4 days of being on that antibiotic, something unusual will start to happen. And that is that your blood will stop clotting. And the way we know about that as physicians is often the phlebotomists, the technicians in the hospital who are drawing blood, will speak to one of the nurses or speak to one of the doctors and say, hey, this person needs some vitamin K, because when I'm drawing their blood, they're continuing to bleed for a long time. They're bleeding through the bandage we put on after. So why is that happening? That's happening because your gut bacteria are intimately involved in making vitamin K, one of the fat-soluble vitamins A, D, E, and K. And so after taking these broad spectrum antibiotics that remove, potentially remove whatever pathogen is causing the pneumonia, but also remove a lot of your healthy bacteria, you'll notice that your vitamin K levels are low. And the way you'll notice that is your blood will stop clotting. So that's just a real tangible example, something I deal with all the time in the hospital, of what happens when we kill off gut bacteria. And your blood clotting might seem serious, but that is one of the least serious things that can happen when you remove gut microbes inappropriately. Our microbiome is also intimately involved in metabolizing drugs and clearing toxins. Sometimes you hear about people being fast metabolizers of drugs versus slow metabolizers of drugs. And that tends to be more a microbial variation than a genetic variation, actually. Our microbes communicate with our central nervous system through something called the gut-brain axis. We know, for example, that about 80 to 90% of serotonin, a hormone we think of as a feel-good hormone because it's associated with sort of enhanced mood, 80 to 90% of the serotonin is actually made in our digestive tract by our microbes. And that's true for other neurotransmitters also, like GABA and dopamine. So this pathway that runs along the vagus nerve, one of the cranial nerves, and all the hormones that go back and forth, these neurotransmitters that signal to the brain what's going on, a lot of them are made in the gut. What's even more interesting is that serotonin is also a precursor for melatonin, the sleep hormone. So if you have a messed up gut, it can affect levels of serotonin so that you have a depressed mood. And it can also disrupt your sleep because then you're not producing enough melatonin. So it's all connected. And when you think about where the gut is located, it's right in the center of your body, right? It's our engine. And we have all these spikes that lead to the brain and the heart and the lungs and the muscles. And it's all connected based on what's going on in the gut. So this communication with the central nervous system is really essential. And we see, for example, that after people have gastrointestinal infections where a lot of their gut bacteria are disrupted, they often will develop mood disorders, being more anxious, having a more depressed mood. We can actually induce that in lab animals when we infect lab animals, mice primarily, with Campylobacter jejuni, which is one of the most common foodborne infections. We can induce anxiety in them after the Campylobacter. We notice that their behavior changes. And we see the same thing in humans. So what's going on in your gut, not just as a result of infections, but as a result of the choices you make every day about the food you eat, medications you take, the environment you find yourself in, all of that affects what's going on in your gut, affects the production of neurotransmitters and other hormones that affect mood and all kinds of other bodily functions. Our gut bacteria are also really involved in something called angiogenesis. And angiogenesis is really the development of new blood vessels, which is something that's really important for maintaining homeostasis in our bodies. Gut bacteria synthesize short-chain fatty acids, and short-chain fatty acids are going to be the star of the show later on in my talk, because not only are they really important for gut health, they're really important for immune health and immune balance. So we're going to circle back to short-chain fatty acids, but I just want you to remember gut bacteria, fiber, short-chain fatty acids, and I'm going to put it all together for you. Our microbes also turn our genes on and off. We think of our genome and the genes that we inherit as being static, right? Like it's just your genes, and what can you do? As my daughter used to say when she was in elementary school, you get what you get and you don't get upset. But it turns out that's not true, because our genes are modulated. They are activated and inactivated by our microbes. So what's going on in your gut with your gut bacteria can actually alter whether a gene is expressed or not and determine whether a disease gets expressed or not. And so that's another thing that our gut microbes do. They influence disease expression. and they train our immune system. So that's why it's so critical to be exposed to sufficient amounts of germs early on as children, and to not live in this super sterile environment where everybody's inside on their device and nobody's out in the woods. Because when you're exposed to microbes in the soil, when you're exposed to coughs and colds and early childhood illnesses, what that does is it trains your immune system so that your immune system can say, hey, this is something really important. We need to, let's mobilize all the killer T cells and the antibodies and let's fight this infection versus, yeah, this isn't so important. You can relax, not a big deal. And a little later in the talk, when I talk about immune balance and this Goldilocks immune system, not too active, not too underactive, we see again that the gut microbes are intimately involved in setting that balance within the immune system. And finally, protecting against pathogens. And there's a number of ways our gut bacteria can do that. They can synthesize substances that are active against other pathogenic bacteria or against viruses or against fungal organisms. They can swap genes that make them resistant. And they can just sort of crowd them out. So there are a number of different ways that our gut bacteria protect us against pathogens. I want to share this animation with you because some of you may not have ever seen a baby being born. So this is just an animation, and I'll tell you why I want you to watch it after we watch it. So here's a baby's head crowning, and notice that the baby is facing down, right? When the head comes out. Let's watch that again. This is one of my favorites. So let's just take a quick peek again. The baby's head is coming out. The face is facing down. And why is that? That's not an accident. That is because that moment when you were born, if you were fortunate enough to be born vaginally, is really probably the most important part of your life. It's not your first day at school or the day you get married or your first day of medical school or your day-to-day joining us for the real truth about health. It's actually that moment, because as a baby's head turns posteriorly to face what we call the perineum, which is that area of real estate between the anus and the vagina, the baby's head turns like that so it can swallow a mouthful of microbes. So it can become colonized with the mother's founding species, with the mother's bifidobacteria and lactobacillus, et cetera. And babies who don't have the good fortune of being born vaginally are colonized with hospital-acquired staph, which is as bad as it sounds. So when we look at the differences between babies being born via C-section and being born vaginally, we see huge differences in allergies, in asthma, in autoimmune diseases, in obesity, and even in susceptibility to viral infections. So C-section births increase the risk of all of this, and vaginal births decrease it. And again, why is that? It's because you need those microbes, right? And if at birth you don't get those founding species, it can follow you later into life. This difference is not just for birth, it also translates into breastfeeding. The third most common ingredient in breast milk is something called an HMO, human milk oligosaccharide. And human milk oligosaccharides are completely indigestible by babies. So why would the third most common ingredient in breast milk be something that a baby cannot digest? It's because it's not there to feed the baby. It's there to feed the baby's gut bacteria. And so the HMOs, the human milk oligosaccharides, feed the baby's burgeoning microbial army and make the microbes in the baby's gut and the baby itself more resistant to staph and other pathogens it may encounter on the mother's nipples. So again, it's this combination, it's this 1-2 punch, right? Of the baby being born vaginally, being colonized with all the important species, and then the human milk oligosaccharides continuing to feed those species. And, it's not just birth and nursing postpartum. It's what the mother eats during pregnancy too. So there's incredible data. There's a fascinating study from South America that shows that mothers who eat during pregnancy a high sugar, very starchy, high simple carb, think a lot of baked goods and packaged goods and sodas and stuff like that. If you're eating that when you're pregnant, that can triple your baby's risk of RSV, respiratory syncytial virus, after they're born. Now, RSV is one of the most common viruses, and most children have had it by the time they're 2 or 3, upwards of 90% of them. But what eating that starchy, sugary diet can do is it can increase the likelihood that your baby's RSV is going to be a severe form of RSV and not just a simple cough or cold, that your baby may actually end up with pneumonia. So it's a really it's a 1-2-3 punch, not a 1-2 punch, because it's what the mother is eating while she's pregnant that is informing what's going on in her microbiome that's going to be transferred to the baby. And then, of course, the nursing. So, I remember when I was in medical school at Columbia and I was doing my pediatrics rotation, and there was a sign in Baby's Hospital, that was what it was called, from La Leche, which is an international organization with the goal of promoting breastfeeding in women. And there was a sign in the clinic saying how not breastfeeding your baby increased the risk of autoimmune diseases like Crohn's. And I remember thinking as a third-year medical student, just scratching my head and going like, huh? How can that be? Like, that doesn't really make sense to me, that not breastfeeding could increase Crohn's. Like, what does breast milk have to do with something that's going on in the gut? So fast forward a couple of decades, and we know that is exactly right. La Leche was spot on, because if you don't have the right microbes and you have a disrupted microbiome, it increases the risk for all kinds of autoimmune diseases, including Crohn's. And that's something we're going to be talking about too. So let's move on. What I want to show you here in this schematic is that there are 4 main families of gut bacteria. And you do not have to remember this, but the 4 main families are Firmicutes, Bacteroidetes, Proteobacteria, and Actinobacteria. And Firmicutes and Bacteroidetes make up upwards of 90% for most of us. And they're all represented, as you can see, by the different colors. So you see the Firmicutes in the kind of pale purple and the Bacteroidetes in the paler blue. Now, there's a big difference, as you'll see, between the microbiome of a baby and an elderly person and even a toddler. And what you'll see is that whether you're breastfed or formula fed, that changes the composition. Antibiotic treatment changes the composition. Malnutrition changes the composition. Obesity changes the composition. And as we get a bit older, that changes it too. And really what we see here is that these disease states, including gastric bypass surgery, any kind of bariatric surgery, metabolic disorders, heart disease, diabetes, stroke, etc., inflammation and cancer, they're all associated with changes in the microbiome. And what is represented here in that little pizza pie slice is proteobacteria. And it's an overrepresentation of proteobacteria in these conditions. Now, it's not just proteobacteria. I don't want you to think like, oh, proteobacteria bad, bifidobacteria good. It's definitely more complex. But this is just a schematic showing you that that is one of the things that happens, in addition to the fact that we go from high to low diversity. Diversity in the microbiome is key. Just like we need diversity in the world to have a healthy world, we need diversity in the microbiome. So let's spend a little bit of time talking about this concept of good and bad bacterial flora. I like to ask people sometimes when I'm giving a talk live, I'll say, all the good people in the room, raise your right hand. And all the bad people, raise your left hand. So I usually have 2 hands raised because sometimes I'm very good and sometimes I'm not so good. Sometimes I'm a little bad. So we all have this potential to be good versus bad, most of us. And the same with gut bacteria. And so we're going to talk about this concept of balance and pathobionts in just a moment. But let's start with some prototypic good bacteria. So those are things like lactobacilli, certain forms of E. coli. But again, E. coli, some of you may know about E. coli 0157H7, that's associated with a very severe illness called hemolytic uremic syndrome. And E. coli 0157H7, that's a subtype, is associated with foodborne illnesses, contaminated meat usually. And it can cause this very severe diarrhea and hemolytic uremic syndrome where there's bleeding in the GI tract and there's also involvement of the kidneys. So that's an example of an E. coli that's not so good, particularly when it's disproportionately represented. But Bifidolactobacillus E. coli, generally the good. Clostridial species can be both good or bad, but one particular kind of Clostridium called Clostridium difficile, we affectionately, or rather unaffectionately, call it C. diff in the hospital. It's responsible for hospital-acquired antibiotic-associated diarrhea that kills about 20,000 people in the US every year. Enterococcus faecalis. That's another bad one. And that one I'm going to circle back to talk about with COVID, because high levels have been found to be associated with poor outcomes in COVID. And there are other ones, Lampylobacter too. So this is just a sprinkling. But really, this is what I want to show you what happens. So it's less about memorizing, oh, Proteo bad or Clostridium bad and Lactobacillus good. It's more about understanding this concept of microbial balance. So in this slide, what I have represented here at the top is really just sort of a normal gut, right? And with a normal gut generally has anaerobic microbes in it. So microbes that basically their metabolism doesn't involve a lot of oxygen. Unlike the lungs, which are getting a lot of oxygen, the gut is typically not getting a lot of oxygen. So the first thing that happens, for example, if you take one of those broad spectrum antibiotics that I was talking about that are given in the hospital frequently, a 7 to 10 day course of one of those antibiotics can remove up to a third of your gut bacteria. And if you think that you just take a probiotic and then you're good, that is really magical thinking. That is not how it works at all. Many of these species are never coming back, depending on what age, whether you're young, where your microbiome is more tender and you can do more damage, versus you're older and you have more resilience. But to get back to this idea of microbial imbalance, so first thing that happens is you have a reduction in the amount of normal anaerobic microflora. Now, this can happen because of antibiotics in one fell swoop. This can happen because you're eating the standard American diet, low fiber, lots of meat, sugar, fat, etc. The second stage is that you see an even greater decrease in the amount of normal anaerobic microflora, and you start to see colonization with some of the more pathogenic microflora. Now, not pathogens like Ebola or SARS-CoV-2 virus or, cholera. Pathogens in the sense of bacteria that are normally present in lower levels, like the Clostridial species. Most of us actually have Clostridial species, and up to 10% of us have C. diff in our gut, but at low levels. And at low levels, C. diff is not a problem. It's when you kill off a lot of the healthy bacteria, and now the C. diff are like, oh, we've got room, let's multiply. Same thing for yeast infection. We all have yeast in our digestive tract and vaginally, and yeast actually play an important role in digestion. But when you kill off healthy bacteria, now the yeast, again, they multiply, they overgrow, and now you have yeast overgrowth. But the problem, when you think about it, isn't the yeast. The problem is the lack of healthy gut species. So what happens here in the third stage is you see an even more significant decrease in the amount of healthy anaerobes. And now you start to see not just colonization, but active reproduction of some of these aerobes and the fungal organisms. And then in the final stage, with severe microbial imbalance, you see a dramatic decrease in the bifido and the lactic acid bacteria. You can barely see, you see just two tiny little representations, and now active reproduction of these aerobes and fungal microflora. But if you approach this as, with this sort of scorched earth approach, like I'm going to get in there and I'm going to kill all these bad bugs, what will happen is you end up also depleting your few little helpful lactobacillus and bifidobacteria that are there. So the goal should always be, unless you're dealing with really a life-threatening serious infection, the goal always has to include repopulation, not just eradication, and sometimes not even eradication, but repopulation. So what we are really talking about here is dysbiosis. And this is a general term. People talk about small intestinal bacterial overgrowth, SIBO. SIBO is a form of dysbiosis. And so when you understand this now, that SIBO is not just too much bacteria, SIBO is imbalance as a form of dysbiosis. So as you see here represented in this graphic, you see lots now of Streptococcus and Yersinia and Aspergillus and Peptococcus and Staphylococcus and Candida species and Klebsiella and E. coli. None of these organisms on their own, when they're represented in a typical low level, are particularly problematic, but it's when they overgrow out of control that we now have dysbiosis. But again, I just cannot stress enough how important it is to recognize that the root cause of dysbiosis is not the overgrowth. It's the undergrowth of the healthy species. And this is really important because people come to see me all the time complaining of things like yeast overgrowth or SIBO. And what they want sometimes when they walk in, they want the most potent antifungal, I've got to kill all these yeast. They want a potent antibiotic. And I explain to them, even if we got rid of all the yeast and all the Klebsiella and the, Yersinia and whatever else, it would just come back if we don't rewild you, if we don't repopulate your gut with healthy species. They're all going to come back. And the main way we do that is not with a probiotic. It's by feeding the bacteria that are already there with the correct foods. Okay. So symptoms of dysbiosis in my neck of the woods as a gastroenterologist, this is what I'm typically seeing. Flatulence. People have an unpleasant taste in the mouth. Sometimes they have an unpleasant odor. They have bad breath. They have burping. They have abdominal pain. They have bloating almost always. They have a decreased appetite, or sometimes they're eating too much and they have sugar cravings, especially if they have a lot of yeast species. They are nauseated. They have diarrhea, sometimes constipation. Sometimes they're having trouble gaining weight. Sometimes they're having trouble losing weight. So these are some of the gastrointestinal symptoms of dysbiosis. But dysbiosis doesn't just affect the gut. Dysbiosis affects the whole body. So what we see is this really intimate interaction between what's going on in your immune system, what's going on environmentally, primarily with your diet, and what's going on in your microbiome. And so, for example, dysbiosis is a root cause behind autoimmune diseases like type 1 diabetes, like inflammatory bowel disease, which is a Crohn's and colitis that I take care of mostly in my practice, what we call fatty liver disease, non-alcoholic steatohepatosis or non-alcoholic fatty liver disease, heart disease, atherosclerosis. I know you have had and will be having more brilliant cardiologists on during the program who will be talking about this. So heart disease really as a dietary disease, obesity, even cancer, colon cancer, for example. We know that there are major disruptions in the microbiome that we can link to certain types of colon cancer, certain kinds of lung disease, asthma, allergies, atopy, kind of allergic reactions, other autoimmune diseases like rheumatoid arthritis and ankylosing spondylitis. And then actually, I'll skip that one and tell you about the gut-brain axis. So we talked about that earlier, but I want to remind you it's bidirectional. So neurotransmitters that can control stress and anxiety, mood, behavior, et cetera, are very much influenced by what's going on in the microbiome. And similarly, what's going on in the microbiome is influencing the brain. So the brain is influencing motility, secretion, nutrient delivery, microbial balance, and the gut is influencing neurotransmitters, mood, stress, et cetera. So it's all very much related. Now let's go back to this slide that I have here, which is just a simple line diagram showing in the last 70 years, this dramatic increase in the amount of autoimmune diseases. Crohn's disease, as I said, one of my diseases that I treat along with ulcerative colitis, type of inflammatory bowel disease, as well as multiple sclerosis, type 1 diabetes, asthma. We have 100, actually, I think the list is about 108 now, different autoimmune diseases. And as you'll see from this slide, the incidence is increasing dramatically. And one of the things that's leading to this increase, in general, just our super sanitized lifestyle, the fact that we're killing off our microbes. We live inside in very sterile environments. We eat highly pesticized and processed food, and we take lots of medications, not just antibiotics, but acid blockers and non-steroidal anti-inflammatory drugs. We consume artificial sweeteners. Antidepressants can disrupt the microbiome. So we're living in a way with our food, with our medications, with our environment that are leading to dysbiosis and creating a lot of these problems. So when we think about gut microbial imbalance and how that leads to disease, we have host genetics, right? A lot of these diseases do have a genetic predisposition, but the predisposition is just the suggestion. It doesn't mean that disease is actually going to develop for a lot of these diseases. So we have mutations that can increase the risk, but we have lifestyle, diet, stress, early colonization, were you born in a hospital via C-section, were you vaginally delivered? So altered exposure to microbes, and then of course, medical practices, antibiotics, etc. So these things can all lead to dysbiosis, and that can guide us to disease or health, depending on what our exposures have been. So let's dive right into the immune system. The immune system really is a network of cells and different proteins, and it's there to defend your body against pathogens and infection, and also against cancer, as you'll see. Our immune system records, our adaptive immune system, the one that's learned, records every encounter it has with different germs. And it has a library that can basically recognize and destroy those microbes when it encounters them again. And the really incredible thing about this is that if you are breastfeeding your baby, your breast milk can alter. If your baby is exposed to an infection, your breast milk changes because it goes to that little library in the immune system and then selects the right antibodies for whatever infection your baby has, if you as a mother have been exposed to it. So that's pretty amazing. And we've seen, for example, with COVID, that mothers who've had COVID can pass on those antibodies to their baby so that their baby is immune. So just an incredible system. And what's even more incredible is that most of your GI tract is actually in your most of your immune system is actually in your digestive tract. It is in these pairs, patches, which are these patches of lymphatic, immunologically active tissue around the small intestine. They're in the appendix, they're in the spleen. They're also up in the adenoids and tonsils, which is why, when I see ear, nose, and throat doctors just really having a pretty low threshold for removing kids' adenoids and tonsils, it really gives me pause because, again, these are immune organs and there may be circumstances, if somebody has terrible strep and an abscess or something and is colonized with that, they may need to be removed, but they're obviously, think back to what I said about rewilding and repopulation rather than eradication. In this sense, not just eradication of the organism, but eradication of the organ. So how can we make these organs healthier? How can we rewild our bodies so that we're not having these recurrent infections? What I want to show you with this slide is the thin layer right here, 1 cell thick, what's called the epithelial cell layer. This is a physical barrier between what's inside your gut and the rest of your body. Because remember, when you eat food and it goes through your 30-foot digestive superhighway, it's not actually inside your body. It is in this tunnel that leads from your mouth down your esophagus into your stomach through the 3 parts of your small intestine, the duodenum, jejunum, and ileum, into your colon, the large intestine. It comes first to the cecum, up the ascending colon, across the transverse colon, down the descending colon, into the sigmoid colon, rectum, anus, out. And all the time that the food and the products of digestion and the millions of bacteria and viruses that you ingest every day also, while they're in that digestive tunnel, they are protected, or rather the rest of your body, your heart, lungs, your innards are protected by this epithelial cell layer. So your innards are not actually your digestive tract. When I say innards, I mean those critical organs are all protected from the outside world, because your digestive tract is the outside world. It just happens to be bifurcating your body. So they're all protected by that cell layer. And that cell layer is porous. It's like a fishing net. It has fine little holes in it. And so as the food gets digested and broken down into its constituent parts, it is able to selectively get absorbed through that net. But the goal of the net is also to keep, for example, toxins, poorly digested food particles, things like that, viruses outside of your body. Now, what can happen, of course, is that net can get damaged. So when you think about what happens when you take a non-steroidal anti-inflammatory drug, NSAIDs like Motrin, those drugs keep me in business as a gastroenterologist. And when I do endoscopy on people, I see little erosions or sometimes big ulcers. And those are literally holes in your gut lining made by those drugs. So even when you don't have an actual big ulcer that I can see or an erosion, those drugs are still typically making little holes in the net. Antibiotics can do it. Infections can do it. Viral, parasitic, fungal, bacterial infections. alcohol, too much of that. So all of these things can harm that gut lining. And when you think about it, this one cell layer, like a razor thin edge, is the only thing protecting your internal organs from the outside world. Like, you had better take care of this membrane and make sure that it doesn't break down on you. And when it does, that's something that we call leaky gut, or an increase in intestinal permeability. So again, on one side of this layer, we have our gut bacteria, these trillions of microbes. And on the inside, just inside, right down here, on the other side of this one cell layer, we have the immune system. We have all these different cells, the T cells and B cells and plasma cells that make antibodies. And it is really a hand in glove relationship between what's going on with the microbes and what's going on with the immune system. And I'll give you an example. The only thing I want you to remember from this slide is what's going on at the top. These three things: fiber, gut bacteria, it's gut microbiota, that's another term for the microbiome. And these things, short chain fatty acids. Remember I mentioned them earlier and I told you I was coming back. So here's an example: butyrate, propionate, acetate, or sometimes called butyric acid, propionic acid, acetic acid. These short chain fatty acids are the metabolites. They are the byproducts of bacterial fermentation of fiber. And as you'll see in this little schematic here, they guide the immune system towards inflammation or away from inflammation. So you can have a pro-inflammatory reaction or an anti-inflammatory reaction, depending on whether you're eating enough fiber so that your gut bacteria have that substrate to ferment to produce these short chain fatty acids. So don't worry about IL-18 and GPR109A and goblet cells and neutrophil chemotaxis. That is not important. What is important is that you understand when you are eating a high fiber diet, you are feeding your gut bacteria indigestible plant fiber, which is the main, and in some cases, the only source that those bacteria need for fermentation to produce short chain fatty acids, which then guide your immune system. Okay. All right. So here's my favorite thing to talk about. I know I'm a gastroenterologist and I should stick to talking about, intestines and stool and so on. But this concept in the immune system is so important. And, when I was in medical school 30 years ago, it just wasn't explained well, to be honest. Immunology was very complicated. It was all those things you saw on the previous slide, right? It was the GPR109A and IL-18 and neutrophil chemotaxis and GPR41 and GPR43. And it was complicated. And it was not necessarily intuitive in terms of how it all worked. And so I love being able to present to you this very basic and simple model about how it works, a balanced immune system. So I want you to pay attention to that green balanced immune system, optimal effectiveness in the middle. And then on the left side are internal threats, and on the right side are external threats. So what happens if you have an underreactive immune system? And there are two typical settings in which that could happen. One is a primary immune deficiency that you're born with, and that would be conditions like SCIDS, severe combined immune deficiency syndrome, where the babies are prone to all kinds of infections and have to live in a sort of more sterile environment. And so the more common would be secondary. That would be a drug. That would be you're taking a steroid or a biologic or some drug that suppresses your immune system, or you have HIV, human immunodeficiency virus, that can cause also a secondary immune deficiency. And what happens there is that internal threats can lead to cancer. And what I mean by that is that when cells multiply, sometimes they multiply irregularly, and the genetic material in the cell is a little off. And normally, if your immune system is active, it's not doing surveillance just for pathogens. It's not just looking for SARS-CoV-2 and Ebola. It's also looking for those faulty cells, right? Those cells that have reproduced a little bit funnily and are off, and they need to be destroyed, because if they don't get destroyed by your body's internal immune surveillance system, they could turn into cancer. When you have an underactive immune system, that doesn't happen, or it doesn't happen as robustly. And so you are at an increased risk for cancer. You are also at an increased risk for viruses that have been dormant in your body. So for example, if you have chickenpox when you were a kid, you're now at risk for shingles because that virus can reactivate. Tuberculosis can reactivate. Varicella, which is a virus that causes chickenpox, can reactivate. HIV can become more active. Hepatitis can become more active. So, with long COVID, which is what we're seeing is a prolonged state of activity or a reactivated state for some people, that's not new for us for viral infections. We see that with hepatitis, we see it with HIV, we see it with varicella, and we see it with bacterial infections like TB, as well as several others. We see it with mono, with Epstein-Barr virus. So we know that viruses can do this. And we know one of the things that will increase the likelihood of a virus reactivating, or a bacterial infection for that matter, is an underactive immune system. Okay, so that's cancer and reactivation of dormant infections as internal threats. These are things that are going on in your body that your immune system should normally be able to fix. But when it's underactive, it can't fix it. And now you have these disease conditions. What about an underactive immune system and external threats? Well, those would be the infections in the first place. So viral infections, bacterial infections, fungal infections, mold, etc. If you have a suppressed immune system, whether because you were born with one, you got a virus that created one, or most commonly, you're on medications, you're treating a disease with a medication, but that a side effect of that medication is that it suppresses your immune system. And that is now putting you at risk for other diseases. That's a problem. That's a problem with our modern medical paradigm. So let's say you were on a big dose of steroids for some inflammatory condition. Now you're at increased risk for COVID, for fungal infections, et cetera, for all these external threats. So that is immune underreactivity. What about an overreactive immune system? I hear people talking about wanting to boost their immune system, and I see people selling supplements to boost your immune system. Well, boosting your immune system is not necessarily a good idea, because boosting your immune system leads to autoimmune problems and allergic problems. And let me explain how that works. Again, left side of the screen, internal. I literally could talk about this slide for an hour. I just think it is so key to understand these concepts. So internal threat. What is an autoimmune disease? An autoimmune disease, remember I told you we have about 108 of them. They affect 1 in 5 Americans. If you don't have one, you probably know someone who does. People often have multiple. They'll have eczema plus psoriasis plus colitis, or they'll have MS plus rheumatoid arthritis sometimes. So why do they have multiple? Because it's the same root cause of microbial disruption for a lot of them. And again, not to overstate it, genetic predisposition plays a role, environmental exposure plays a role for sure. And for some of them, for example, there is fascinating data that has just come out in the last few weeks about MS, multiple sclerosis, a disease that can be devastating, being related to viral infection. EBV, the Epstein-Barr virus that's associated with mono, is now thought to be one of the main causes of MS. Not always, and not the only, but an important one. And we know that Epstein-Barr virus can also lead to a kind of lymphoma. So it can lead to cancer or autoimmune diseases. So to get back to autoimmune diseases, so we're talking about things like Hashimoto's, thyroiditis, rheumatoid arthritis, lupus, Crohn's, colitis, type 1 diabetes, etc. Your immune system is overreacting, and it is reacting to your body's own normal tissue. In the case of Hashimoto's thyroiditis, it's reacting to your thyroid. In the case of colitis, it's reacting to your normal gut bacteria and your intestinal lining. In the case of rheumatoid arthritis, it's reacting to your own joints, right? So it is treating self as the enemy. There's self and non-self in the immune system, and it is mistakenly looking at self and calling it non-self and saying, oh, this is a problem, this is a pathogen, we need to react. In the case of external threats, it's allergic reaction. So it's, severe peanut allergies, food sensitivities, allergies, eczema, hay fever, things like that, just reacting to the pollen in the air. And I want you, let's even go back a couple slides. I want you to remember this. I want you to remember fiber, gut bacteria, fermentation, short-chain fatty acids, healthy immune system, anti-inflammation, right? This is not an accident how this stuff happens. And it's not always your fault. But what I want to tell you is that most disease does not just fall from the sky in our laps and flatten us. We can follow those breadcrumbs backwards to figure out where this equation went wrong. Maybe it was the dose of steroids you were prescribed by the doctor. Maybe it was the massive amount of antibiotics you had as a kid that disrupted your microbiome, or the standard American diet you've been eating. But what I am passionately about is helping people understand and find the root cause so that they can ideally reverse some of these processes. They're not always reversible, but many of them are. Okay, let's keep going. Let's quick check of the time. Okay, we're doing fine. So I want to tell you now about 2 or 3 of my favorite studies. This one, A Tale of Two Cities, is a study that was published several years ago. I first read about this study in the Economist, actually, not in a medical journal, although it was in all the medical journals too. But it's a study by an Italian pediatric gastroenterologist named Paolo Leonetti from University of Florence. And he did a study looking at babies born in Florence who are eating very much standard American diet, pizza, ossobuco, gelato. So high fat, high animal protein, high sugar, low fiber. And he compared about 14 of those kids, those babies in Florence, Italy, with a cohort in Bulpon, Burkina Faso. Now, in Bulpon, Burkina Faso, people still live like their Neolithic ancestors did. They are primarily gatherers still, and they farm subsistence farming. So the diets could not have been more different. The kids in Florence, again, now, very important to know that both groups of kids were vaginally born and breastfed. And what he found is, as infants, the microbiomes were virtually identical. But as soon as the babies migrated or sort of graduated to table food and were eating their local diet, everything changed. So what were the babies, the toddlers in Florence eating? They were eating high fat, high animal protein, high sugar, low fiber. What were the babies, the toddlers in Burkina Faso and Bulpon eating? They were eating a plant-based diet. They were eating grains like sorghum and millet that they would sort of grind it on a stone into a thick porridge that they would eat with vegetables and with herbs. And that was their staple. In the rainy season, they ate some termites as a form of animal protein. And on special occasions, one of the chickens running around the village would find its way into someone's pot. But it was by far a diet of unprocessed whole grains and root vegetables and herbs. And what did they find? This study was published as the impact of diet in shaping gut microbiota. And again, European children consuming a Western diet, they had a greater abundance of gram-positive bacteria. Well, we'll talk about what that means. The African children eating the high-fiber vegetarian diet, they had a greater abundance of Bacteroidetes, higher microbial richness, so more microbes in general, more species diversity, very important marker of a healthy microbiome, lower prevalence of pathogenic strains, and the most important thing here, they had high levels of short-chain fatty acids. In fact, they had double the levels of short-chain fatty acids compared to the European children. So what's really interesting too is that the Italian children had bacteria growing in their microbiome once they were eating the Western diet that are associated with diarrheal disease, that are associated with obesity. The African kids had bacteria associated with leanness and low levels of inflammation, and again, double the short-chain fatty acids. But what I want you to realize is that neither group of kid were sick. We're talking about completely healthy toddlers. But what we are seeing the foundations for disease being laid down early based on the diet. So as early as when they first started eating table food, we start to see the microbiomes changing and going in these two different directions. One of which, now let's be clear, the African children, they have to worry about malnutrition. They have to worry about tuberculosis and malaria. So, it's not a bed of roses for them, but what they don't have to worry about is autoimmune diseases and dying from COVID and having obesity and diabetes and hypertension and stroke and heart disease and all the rest. That's what's in store for the Italian children based on the way they were eating. Okay. Somebody just said, I don't know about European children, but most American toddlers have already had a dose of antibiotics by the time they're toddlers. Annette, that is actually correct. In fact, most American children have had 18 courses of antibiotics by the time they graduate from high school. But let's get back to these two nutrition studies. So that was a study from Italy, Paolo Leonetti, African kids, lots of fiber, high short chain fatty acids, lots of good bacteria. European kids, lots of fat and animal protein, low levels of short chain fatty acids, bacteria associated with obesity and diarrhea and inflammation. Okay. Now, you might say to me, well, Dr. Chutkan, that is really interesting, but what if it's not the food? What if it's the environment? The people in Bulpan, Burkina Faso are eating like it's the Mossi tribe, the Mossi ethnic tribe. And they're not just eating like their Neolithic ancestors, they are living like their Neolithic ancestors. They're living in adobe huts. Let's see if we can go back. So we'll see. Oh, I don't have a picture of one of the huts, but they're living in these huts surrounded by animals. They have dirt floors. So they're living in close contact with lots of soil microbes. Maybe that was a reason that they had this healthier microbiome. So here's a study. It's one of my favorite studies. It's done several years ago now, published in the journal Nature in 2014. And this study showed that diet rapidly and reproducibly alters the human gut microbiome. And why I love this study is that we all know that if you eat differently, your microbiome will look different. But did you know how quickly that happens? So in this study, this is a study done by Harvard researchers in Boston. They took 9 volunteers and they put them first on basically an Atkins diet, on, what's pictured on the left side of the plate. So it was prosciutto and pork rinds and eggs and beef. And I believe it was pork rinds for snack on that diet. They put them on that diet. I'm getting heartburn just thinking about that. But they put them on that diet for 5 days. And they looked at the microbiome before, during, and after. And then they rested those same volunteers, and they did not change their environment. And a week or 2 later, they put them on a plant-based diet. Nothing crazy, jasmine rice, lentils, tomatoes, but mango and banana for snack instead of pork rinds. And they looked at the microbiome before, during, and after. And what they saw microbially, the biggest change was a decrease in what they call the bibliophilia, the bile-loving bacteria. And bibliophilia are important and necessary for breaking down fat that's in animal protein. So we know that if you go from eating a high animal protein diet to a low animal protein diet, the bibliophilia will drop. But what was fascinating and unexpected was that the genes changed also. So the bacteria changed within about 30 hours of the food hitting the gut, which means that right now it's Friday about noon EST. By Sunday, you can have a different microbiome. It's amazing, right? I mean, remember genes. You get what you get and you don't get upset, but even your genes will change, because what they found in this study is that with a dramatic shift in microbes due to the dramatic shift in diet, there was also a dramatic shift in the genes that were turned on and off, which means that you could be born with a set of genes that predispose you to something, and based on how you eat and changing how you eat and incorporating large amounts of fiber, even if you don't become vegan, you don't have to be vegan. But if you significantly increase the amount of plant fiber you're eating, you can prevent that disease from being expressed. And to me, that is the most optimistic, fantastic news that I have ever heard in my entire medical career. And it's not just news, it's fact, it's science. Okay, let's keep going. Here's a good time to pause for a little bit of definitions because we've talked about short-chain fatty acids and fiber and bacteria. So I want to make sure, I know you guys are very sophisticated, but in case there's some of you out there who are a little new to the whole concept of the microbiome, let me go over just 3 simple definitions. The first is, what is a prebiotic? Prebiotics are basically dietary fiber. They're a type of specialized fiber that supports the beneficial microbes that live in your gut. Right. And there are very few bad types of fiber, except the fiber that comes out of the factory, the processed fiber. So whether it's artichokes or asparagus or broccoli or kale or spinach or, Brussels sprouts, whatever plant food like that you're eating, or oats. So that kind of dietary fiber is a prebiotic. And here I want to emphasize something. I want to tell you that a prebiotic from nature, an actual plant food that you eat, is always going to be superior to a supplement prebiotic. And I don't care what marketing they have on it and, blah, 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 eating the actual food. And I'm telling you, I've been a gastroenterologist for 30 years, and I have looked at thousands and thousands of colons and stomachs. And I'm here to tell you that the food is always going to be better than the supplement. No matter what fancy marketing rationale they tell you, well, the soil wasn't good and this wasn't good and that wasn't good, eat the food. Okay. Now, it doesn't mean a supplement may not play a role if you're low in some particular thing, but don't think that you can just take a prebiotic supplement while you are having your pizza and think that like, oh, good, I fed my bacteria. It does not work like that. Now, what is a probiotic? A probiotic is a live microorganism that, when ingested, confers a benefit to the host. That's the World Health Organization definition, right? Live bacteria organism that, when ingested, confers, and ingested could be by the mouth, it could be rectally with a stool transplant, confers a benefit. The confers a benefit part is tricky, and the live part is tricky because what we see with a lot of these probiotics on the shelf is that A, the bacteria in them are dead, and B, they do not confer any benefit when you take them. Probiotics technically also refer to your own bacteria in your gut. But, in general parlance, when we refer to a probiotic, we typically mean an external thing that you take. Okay. So the prebiotic, the fiber, gets fermented by the probiotic, the bacteria, but really typically not the probiotic supplement you're taking, but the biotics, the biome, the microbes in your own gut. And they produced postbiotics. These short-chain fatty acids we talked about, they're sometimes called a metabolic byproduct, but they are basically postbiotics. And again, short-chain fatty acids are not the only postbiotics. It's referring to bacterial byproducts that affect a range of physiological processes, because what we've realized is it's not just what bacteria are growing, it's also what they're making, and that can change. So certain strains of bacteria can shift what they're metabolizing based on what you need, or, if it's something a little more pathogenic, they may be making something you don't need that's causing a problem. So understanding this whole concept of metabolomics, not just ours on a macro level, but the bacterial metabolomics on a micro level, is really important because, for example, we see that sometimes the gut bacteria, even the good gut bacteria, are not making really significant amounts of short-chain fatty acids. And we have to think of why that's happening, and why that's happening maybe because they don't have the substrate. So you may have lots of good bacteria, but the amount of prebiotic you're eating, the dietary fiber, is low. And so you're seeing a drop in the postbiotics, in the short-chain fatty acids, et cetera. So just counting the bacteria alone doesn't give you the whole story, because again, you need to know, what's actually happening with the metabolic byproducts. All right. So here now I want to spend a minute telling you about my absolute favorite bacteria in all the world, and that's Faecalibacterium prosnitzii. We call F. prosnitzii. This is just a scanning electron microscope picture of it. F. prosnitzii has a protective role in metabolic diseases. So in things like heart disease and diabetes, et cetera, and in metabolic syndrome, that sort of compilation of lipid disorders and central adiposity, central obesity, that can lead to an increase in stroke and heart rates and a higher risk of dying. it is strongly correlated with short-chain fatty acid production. Why? Because F. prosnitzi is one of the bacteria that make short-chain fatty acids. It's more prevalent in vegans, no surprise there. And again, it's associated with a decreased risk of heart disease, of cancer, of diabetes, of obesity, and it has a protective role in COVID. And I'm going to tell you in a minute how that works. But I want you to remember F. prosnitzii, one of the good guys. Now I'm going to digress a little bit to talk about inflammatory bowel disease, just to give you enough background to explain some of the data from our practice. So inflammatory bowel disease is Crohn's disease, ulcerative colitis. They are familial diseases in the sense that there's a genetic predisposition sometimes in a minority of patients. With Crohn's, it's about 25% of patients. With ulcerative colitis, it's significantly less. And it involves dysregulation of the mucosal immune system. Remember, I showed you that diagram with the little, the gut lining and so on. So there's a dysregulation of what's going on there between the microbes and the immune system. And basically, the immune system is overreacting to normal commensal microbes. It's reacting to the healthy, regular bacteria in your gut as though it was an enemy, and it's making a reaction. And in this case, the reaction it's making are these ulcers, okay? The microbial signature in Crohn's disease, we see these microbial signatures in a lot of autoimmune diseases. And again, I don't want to oversimplify this and give you the impression that everything, you just have to eat some kale and all is well with you in the world. But because there are other factors, as I've said, there are environmental factors or genetic factors, et cetera. But what we know is that a lot of autoimmune diseases have these signatures. And with Crohn's disease, we see an increase in mucosal associated bacteria. We see a decrease, not surprisingly, in microbial diversity. And we see a decrease, again, here, no surprise, in production of butyrate, one of those really important short-chain fatty acids. So we know diversity is down, production of short-chain fatty acids is down, and then we see low Faecalibacterium. No surprise there. I told you that was one of the good guys. And we see an increase in some of the invasive E. coli. Okay, so what I'm trying to do here is set the stage for you with this as an inflammatory condition that has its root in microbial imbalance. Okay, so this was a study that we presented at our International GI Conference, Digestive Disease Week, a little less than 10 years ago. It was myself and Jenna Hamshaw, who was a dietitian who was working with me at the time, a nutritionist, and who, by the way, has a couple of great books out there. If you're interested, she does. I do too, but she does also. So this was a retrospective review to assess the effectiveness of a modified specific carbohydrate diet in improving quality of life and reducing frequency and severity of flare-ups in patients with inflammatory bowel disease, IBD. Now, I want to be clear, SCD, specific carbohydrate diet, is not a diet that I use in my patients typically, but this was a retrospective review. It's a common and popular diet for inflammatory bowel disease. And the reason I don't typically use it is sort of a modified third cousin of a paleo diet, which can be a very low fiber diet. But these were patients who were coming in on this diet and saying that their disease was better. So we said, okay, let's take a look at what they're doing and what they're eating and see what's going on. And these diets are these diets don't have like a cutoff grams of fiber amount or grams of carbohydrates, like in Atkins or South Beach, where there's a certain typically level of carbohydrates that they want you to stay below. These diets are more qualitative than quantitative, but they do exclude certain food groups. And some of the food groups they exclude, like gluten and processed carbs and sugars, can be helpful, but they can sometimes also limit fibrous foods depending on how you interpret them. So let's take a look at what these patients were doing. The age range, there were 12 patients, 9 female, 3 male. Mean age was 39.25, 9 had Crohn's, 3 had ulcerative colitis. The mean amount of disease was 10 years, but there was a range, 2 to 23. And this one is important, the past surgery. Almost half the patients had had previous surgery. And that's important because that's a marker for more severe disease. So these weren't people with, mild occasional symptoms. These were people with serious disease. The time on diet before improvement varied a lot. This is a time on diet in days, but really around 60 days, by 2 months, if you hadn't responded. And this is how I use as a guide in my practice. So my sweet spot in my practice is nutritional therapy for patients with complicated autoimmune disease like Crohn's and ulcerative colitis. And when I give them the dietary guidelines, I will tell them, like, look, hit this hard for the first couple months, because it's important for us to know. It doesn't mean you have to stay on this strict a diet forever, but I want you to hit it hard so that at the end of 60 days, we can see if you've had no improvement at all, then it is unlikely by that point that your disease is going to be responsive to just diet alone. It doesn't mean you should stop the diet, but it means that we may need to use some more conventional medications too. And so some of this information we know from this study. So mean time on diet before improvement, 38 days. But again, 60 days was sort of, where we saw most people having significant changes. The number of patients who were able to stop or decrease medication was 7 out of 12. Number of patients able to stop completely was almost half, 5 out of 12, and 2 out of 12 were able to decrease. And again, these are not medications like aminosalicylic acid medications that are pretty benign. These are patients who are on biologics and steroids, so serious immune modulating drugs. This is an example of a before and after. This is somebody's colonoscopy here. I mean, you don't have to be a gastroenterologist to see these deep ulcers and inflammation. And this is what it looked like after normal. So our endoscopic results, we did colonoscopy in 8 out of the 12 patients, 6 out of the 8 showed mucosal healing. And so we were able to conclude that nutritional therapy is a viable therapeutic option for management of inflammatory bowel disease. It can result in improvement of symptoms. It can result in mucosal healing, and it can result in a reduction or discontinuation of medication. The most important thing about this study, what it taught us when we really dove deep into what people were eating and had them bring in their food journals. Actually, I was just having people take pictures of the food because I found that was easier for people than a food journal. So I just have them take their phone, and every time they ate something, they'd take a picture, and then they would just send me the photos. And so we saw there was a crystal clear direct correlation between improvement and the amount of dietary fiber consumed. So people who were interpreting this diet as, I'm going to have bacon and eggs for breakfast, I'm going to have chicken for dinner, for lunch, and I'm going to have steak for dinner with a few broccoli florets, no bueno. Those patients were not doing well. It was the patients who were really ramping up their dietary fiber. And when there's active inflammation in the gut, that can be tricky. So we use a lot of green smoothies to blend the fiber. We use a lot of soups. We do a lot of legumes in a pureed form to get the fiber in a way that's a little less abrasive to the gut in our patients with active inflammation. And we also have a phase 1 and a phase 2. And in the phase 1, we have to go much more slowly with the fiber. And when people are in active flare-ups, and then as their disease quiets down, we can generally ramp up the fiber. So I just also, if there are any of you out there with inflammatory bowel disease, want to be clear that we don't introduce, 80 grams of fiber into an inflamed colon. That typically is not going to go well. So what does this anti-inflammatory diet look like? That, as I said, is the same diet that's an anti-cancer diet, and it's an antiviral diet. It's lots of high fiber plant matter in the form of fresh vegetables and fruit. It is micro-boosting whole grains and legumes that contain what we call MAC, M-A-C, microbiota accessible carbohydrates. So that's the oats and the brown rice and the lentils and all of that. And it's the option of a small amount of protein and fat from animal sources for patients who need it, but your gut certainly doesn't need it. So this is just a conclusion from an article in the Mayo Clinic Proceedings from years ago, well before COVID. And what that told us is it was a special article about biodiversity in the human gut. It told us that greater microbial diversity is associated with better ability to deal with stressors like pathogens. And it told us that individuals with a disease are more likely to have alterations in gut microbial communities and low diversity. So remember that early quotation from Hippocrates. It is more important to know what sort of person has a disease than what disease a person has. What sort of person has a disease? Individuals with a disease are more likely to have alterations in gut microbial communities and low diversity. Individuals with a disease are more likely to have disruptions in their gut microbiome. And where does that greater microbial diversity and richness come from? It comes from what you eat. comes primarily too. I mean, if you're taking antibiotics every day, that's going to be a problem too. If you're taking acid blockers that kill stomach acid, that decrease stomach acid and disrupt the natural pH in the gut, that's a problem too. But by far and away, as adults, and one could argue as children, the number one, and I make that caveat with kids because the kids' microbiome is very tender and sensitive to the effect of drugs. So don't medicate your children unless it's really necessary, particularly antibiotics. Be very thoughtful about that because those first 1,000 days, which is about the first, 3 years of life, when the microbiome is really forming, is when it, destroying microbes in young babies at that age can lead to serious problems later on in life. And that's actually how I got interested in this field, because my daughter was C-section, my breast milk dried up after 6 weeks. I got antibiotics during delivery. She got antibiotics at birth. She got put in the NICU, the neonatal ICU, even though she was healthy because I had a fever and I had the flu. They put her in the NICU just in case. They gave her potent IV antibiotics at birth just in case. And again, she didn't have the benefit of a vaginal birth. My breast milk dried up, probably as a result of the antibiotics. And she proceeded to basically be sick almost every day for the next 3 or 4 years. She received about 20 courses of antibiotics before the time she was 2. And she was a very, very, very sick infant and child until I sort of had my aha and realized that all these frequent antibiotics were making her worse rather than better. And I want to be clear here. I'm a physician. I'm in a very good position to assess for my child whether she needs antibiotics or not. I want to remind you that please involve your healthcare practitioner in that decision. Okay, so I'm not in any way advocating that you stop giving your children antibiotics, but I am strongly advocating that you really question that need for antibiotics. Studies show that pediatricians prescribe antibiotics 67% of the time when they 63% of the time, when they perceive that the parents want an antibiotic, and only 7% of the time when they don't. So there's a huge gray zone there for when an antibiotic is really necessary. So again, this greater microbial diversity, better ability to deal with stressors like pathogens. We want our kids to have a fighting chance, and to have a fighting chance, not just against COVID and other viral pandemics to come, but against autoimmune diseases and allergies and asthma and obesity. They need to have a healthy microbiome. But to get back to this idea of the number one predictor, the American Gut Project, a couple of years ago in 2018, published a study where they looked at over 53,000 participants. And they found, and I'm sure other speakers throughout the conference have mentioned this, or others will, because this is really a landmark study. They found this magic number of 30 different plants a week, not 30 plant servings, different plants. Eating 30 or more different plants a week, no matter what kind of diet you on, whether you're a vegan, vegetarian, omnivore, that was associated with a much healthier, more robust microbiome. And eating 10 or fewer plants was associated with a much less healthy microbiome. So, for those of you out there who are picky eaters, who have picky eaters where you're like, yeah, I eat vegetables every day, but I only eat broccoli and carrots. That's two a week. Broccoli and carrots are great, but you need to really think about the variety. So I have a couple food rules that I'm going to be sharing with you, not really food rules, I'd say food guidelines that I share with patients. And I've had to modify them beyond just the servings of vegetables to really think about different types of vegetables. Okay, let's keep going because I want to make sure that we have the full time for our Q&A. And okay. So now I want to use everything we've talked about to tell you this study, which is not going to come as a surprise to you now. Gut microbes predict severe COVID-19. This is a study from last year, and it showed that the most reliable predictor of outcome, death, ICU, need to be on a ventilator after COVID, was a microbiome. It was more accurate than age, gender, presence of comorbidities like heart disease, lung disease, et cetera, inflammatory markers that they check in the blood, like C-reactive protein, et cetera. More predictive than all of that was the health of the microbiome. The composition of the microbiome predicted severe respiratory symptoms and death with 92% accuracy in this study. And what were the two main things? High levels of Enterococcus faecalis, you might remember that as one of the bad bacteria on an earlier slide, correlated with poor outcome. Low levels of my best friend, Faecalibacterium prausnitzii. If you don't have enough F. prausnitzii, chances are you're not going to do well with COVID-19. And how do you get a lot of F. prausnitzii? By feeding your F. prausnitzii fiber. I mean, I wish I could make it more complicated and sexier than that. You know, sometimes people come to see me from far away. I had a patient came from Australia once. I've had people come from France. And I'm sitting there sometimes struggling, like, how can I make this seem worth the trip? Eat more vegetables. You know, I mean, yes, that's a simplification, right? There's more to digestive diseases and eat more vegetables. But I'll tell you, eat more vegetables is a really big part of the message. So F. prausnitzii, just to remind you again, great for heart disease, colon cancer, diabetes, obesity, and COVID. So this is one of my favorite things to remind people. It's less about the potency of the pathogen and more about the health of the host. And when I say health of the host, I'm not talking about you. I'm talking about your microbes. So it's less about the potency of the pathogen and more about the health of your microbes. So what should we be eating? Eat more plants. That's simple. Michael Pollan, in his great book, In Defense of Food, said, eat food, not too much, mostly plants. And I will add to that with just eat more plants. Even if you're already eating a lot of plants, eat more. Choose your carbs carefully. And by that, I mean, you know, carbs kind of have a bad rap by some people. People think carbohydrates make them fat, which is completely not the case. But you want to really distinguish between simple carbs that are going to release a lot of glucose into your bloodstream and cause a spike in insulin secretion, which can cause a lot of those calories to be stored as fat and create other metabolic disturbances, versus complex carbohydrates. So the grains and the legumes and so on. And also things like resistant starches and foods that are high in inulin. I know you've had a lot of food talks during this, so I'm sure people have explained those concepts, but basically these are starches that act more like fiber in the body. Ferment your food. We didn't really have much time to talk about that, but fermented foods like sauerkraut and kimchi are the rock star combination, powerhouse combination of prebiotic and probiotic. Prebiotic because sauerkraut is made from cabbage, and cabbage is a high fiber food that's feeding your microbes. And then also probiotic because as the cabbage is fermented, it creates a lot of lactobacillus. So you're getting a 2-for-1. And fermented foods are really rock stars for the microbiome. And there are lots of studies showing that eating fermented foods regularly, particularly fermented foods that are fermented in small batch that you acquire from a farmer's market rather than the shelf-stable ones in the supermarket, can be actually more impactful than a probiotic in some cases. Eat dirty food. By that, I mean, eat food with dirt on it from the farmer's market. When I buy stuff from the grocery store, I mean, every carrot is exactly 4.2 inches. It's a perfectly orange color, and it just doesn't look like anything that came out of nature, versus a farmer's market where the carrots are ugly. They have little bumps on them. Sometimes a carrot looks like it has like a second little piece coming out. They're stumpy. And they're not necessarily that attractive, but this is how nature made them. And this is how you can guarantee that you're getting food that is grown with exposure to soil microbes. It's not industrial farming in a warehouse. It's actually grown in nature with exposure to soil microbes so that when you eat it, in addition to the nutrients, you are also getting those microbes. So support your local farmer, whether at the farmer's market, participate in a CSA, community-supported agriculture. Manage your meat intake. There are lots of reasons to eliminate meat completely. It's good for the planet. It's great for the animals, and it's really good for us. But if you are somebody who feels like that's not a step that you want to make or can make, manage your meat intake. And so I recommend to my patients not more than one animal protein meal a day. And that doesn't mean eggs in the morning and then like a cream sauce on something at lunch and then meat at dinner. Those are all animal proteins. So if you're going to have, a big bowl of scrambled eggs in the morning, then have salad for lunch and rice and beans for dinner. Or so not more than one animal meal a day. Say no to sugar. It's so hard. Or eat, dark chocolate, things like that, but try not to eat large amounts of refined sugar. I'm not going to try and convince you that sugar is a drug or any of that. but sugar's not great for you, right? So don't eat too much of it. Maybe you don't say no to sugar every day, but try and eat less. Say yes to the farm, no to the factory. People sometimes will have these arguments with me. They'll show me a bar, a nutrition bar, and be like, well, they start reading the label. It has 14 grams of protein and this net carbs and blah, 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 blah. And I'm like, yes, but where was that made? Can you show me a tree? Can you point to a picture of a tree where that, breakfast bar was picked from? So food that makes a stop in the factory on its way to you, try and avoid that, which means yes to an apple, not so much to applesauce. Yes to lentils, not so much lentil chips, right? Because in the factory, those foods are processed. I mean, remember, we can make car tires from corn. Okay. So that should tell you something about how we can process food. So yes to the farm, no to the factory. Avoid frankenfoods. It's foods that have been genetically modified, foods that are highly pesticized, grown with glyphosate, artificial sweeteners, things like that. Things that don't exist in nature typically. Follow my 1, 2, 3 rule, which is 1 vegetable for breakfast, 2 for lunch, 3 at dinner. Quite frankly, I flip that most days because I like to start my day with a green smoothie, which is typically at least 3 or 4 vegetables. In mine, I typically use a coconut water base, just unflavored, unsweetened coconut water. And then I will use collard greens and kale, or collards and spinach, depending on what I have. I put in a stalk of celery. I always try and put in some fresh parsley for flavor. And then I'll put in whatever fresh fruit I have: nectarine, mango, kiwi, maybe frozen pineapple or mango if I don't have fresh, a little squeeze of lemon juice and some ice. So typically, how many plants is that? Not counting the coconut water, it's the kale, the collards, the parsley, the celery, the lemon, and the fruit. So that's 6 right there. That's all 6 in one go. But my 1, 2, 3 rule is really for vegetables. So you wouldn't get credit for the lemon with that. So I used to just tell people 6 servings of vegetables a day, but now I tell people 6 servings of different vegetables a day, right? Not just the same broccoli. And that's important because of what we know from the American Gut Project about the variety of plants. Okay, these are some of the foods that we tell our patients to emphasize: fermented foods, foods that are high in inulin, onions, leeks, leafy greens, cruciferous veggies, garlic, another high inulin food. Asparagus. With asparagus and broccoli, remember to include the stems because that's where most of the fiber is. It's not in the broccoli floret, it's in the stem. So chop that up and make sure you're including that. Green bananas, chicory root. Again, these are examples of resistant starches. Radicchio, carrots, radishes. Everything from the ground basically is good. So if I were to ask you in this final moments together before we go to the Q&A, if I were to ask you what you think the biggest predictor of health is, or I could turn the question around and say, what do you think the biggest predictor of poor outcome to COVID is? Is it obesity? Is it heart disease? Is it diabetes? Is it asthma or cancer? Is it a mood disorder or being very stressed out? Is it autoimmune disease or metabolic syndrome? It's actually your microbiome. It's, those trillions of microbes that inhabit our bodies, mostly our gut, that are the most accurate predictor of health, of outcome to viral illnesses like COVID. And, you can't have a healthy microbiome if you're eating Cheetos and cheeseburgers. Like, you have to feed it the right food. And I saw this picture and I just thought it was just so beautiful. It really is. Like, you look at this picture and I feel healthier just looking at it, not even eating it. It's a bowl. It looks like some quinoa and seeds and broccoli and some citrus, and maybe some beets and avocado and sprouts. And you feel healthy looking at it. So I want to introduce this idea of immune bliss. So my first book is called Gutbliss, but this concept of immune bliss, which is going to protect you from cancer and infection and autoimmune disease and allergies, begins with a high fiber diet. And that leads to a balanced immune response. And that leads to an anti-inflammatory response. And that leads to resistance to illness. So again, all disease begins in the gut. Hippocrates said it a few thousand years before I did, but I second that. And my first book, Gutbliss, second book, The Microbiome Solution, third book, The Bloat Cure, and my new book, The Antiviral Gut, that I have been laboring with for over a year and just went in to be copy edited, will be out actually fall 2022. And I'm really proud of that book. I have to say, I learned a ton. I read about somewhere between 8 to 10 articles a day for the better part of a year writing that book. There's a lot of immunology and microbiology in there, in addition to the GI stuff. And it sort of had a different purpose. You know, the purpose for Gutbliss was really to help people recognize what can go wrong in their GI tract and fix it. The microbiome solution was really to drill down more into the microbiome and autoimmune diseases. The bloat cure was a fun, quick, A to Z, 101 things that bloat you, kind of a page each. But with the antiviral gut, I realized that, people were dying. People were not understanding the relationship between what's going on in their gut and their susceptibility to illness. And again, not to suggest that, I can prevent people from dying necessarily, but a lot of these deaths we know are preventable based on the comorbidities that people have and what is really driving a lot of this disease. So it felt like a very different mission and purpose, and I'm really proud of it. And I hope you all buy it when it comes out. So I am going to stop there, and we'll take some questions. And I'm not sure how you want me to do that. I'm going to
thank you, doctor. This is Ben from The Real Truth About Health. I'll jump in right there for you and not leave you dangling. So wow. First of all, thank you. What a thorough and really, really meaningful presentation for all of us. And really, really phenomenal. I know I speak for everybody on that. That said, we'll jump into our Q&A. We have some time for that. And I just want to make sure that you and everybody else knows how we go about that here. We normally don't take questions directly from the chat box. And what we do is we ask everybody to raise their virtual hand. Like you can already see the hands are flying already, which is great. For those people that don't know how to do this, all you need to do down at the bottom of your Zoom window, you'll see different tabs. One of those tabs is called your reactions tab. You click on your reactions tab and different emojis will pop up. And one of them says raise hand. You click on raise hand and we'll see your hand come in. And so we take them in the order in which we receive them. I will call your first name and I will unmute you. And then you'll go ahead and have your question answered by Dr. Chutkan. So if you're ready, Doc.
I'm ready. And I just want to say, I just took a quick peek at the chat, and thank you so much to everybody who wrote those really nice comments. I so appreciate it. It really made my day. Thank you so much.
I know it's all from their hearts as well. So thank you. And I agree with them. And so thank you. And with that, we'll jump right in. Our first question is coming in from Stephen F. Stephen, welcome.
Good morning. Wow, what a presentation. Okay, let's get to it. A lot of us folks, right? Me, born in 1960, C-section, no breastfeeding, no donated breast milk, didn't exist then. A couple of years later, really bad pneumonia, tonsils out, weight problem my whole life. I adopt a whole food plant-based diet as an adult because of inflammation and pain. Wind up with autoimmune, thyroid, Hashimoto's, lupus, find Goodbye Lupus, Dr. Brooke Goldner, smoothies, wonderful. Everything stabilizes. Hashimoto's reversed. ANA, double-strand DNA, not getting worse. Everything's stable. Avise test comes back negative. Epstein-Barr still always high. And then we're here. A lot of us in the audience are smoothie shredders, right? We've got this autoimmune thing. We found Dr. Goldner, and Robert Lustig goes after our smoothies again. Tells us that the Vitamix breaks up the cell walls and wipes out the insoluble fiber and raises the blood sugar. We know from our own experience that it doesn't raise the blood sugar, and it reverses diabetes, and heart disease stabilizes, and kidney function comes back, and liver function comes back. But is there, and we've been here before, right? Dr. Khan published an article debunking the last thing that the plant-based docs went after the Vitamix. Dr. Clapper said you weren't born clutching a Vitamix. Dr. Esselstyn says you can't get the enzyme from your tongue. And then Dr. Kahn publishes, says, well, you know, you can't fool the body. The enzyme finds the nitrites and converts them, and all is well. Sounds like you could put that fiber myth to bed with your own experience. I don't know if there's
I can help
studies.
With this. Yeah. And Stephen, first of all, you had your hand up so early. So thank you for your patience and for, being the first one there. I love it. I met Brooke Goldner at a conference years ago. It was the Plantrition Conference. And I think she's the real deal. And I'm so glad you found her and she's been helpful. And I mean, you have overcome such a lot, the tonsillectomy, weight issues, 2 autoimmune diseases. The proof is in the pudding. Let me tell you, if I could only have my patients do one thing, it would be do a green smoothie every day. And I, like you, as somebody who has serious autoimmune disease, I see patients with bloating and irritable bowel syndrome, but my bread and butter in my GI practice are patients with Crohn's and ulcerative colitis who are sick. They have real disease. And the thing, more than anything, more than the probiotics, more than the medication, the thing that I see turning my patients around are the green smoothies. And my Vitamix, I used it so much, my thing broke. They sent me, it didn't break, but it was, old. They sent me a new one. I have one of the old basic ones. I think the Vitamix is as close as I get to magic in the kitchen, because I know even for me, and I'm fortunate to be pretty healthy, that I drink that green smoothie in the morning and I feel completely different. I literally can feel my cells and microbes vibrating. So here's the deal. Like, you've been doing this. Dr. Goldner recommended it. You've been doing it and it improved things. It reversed things. So, regardless of what people are telling you, that blending up vegetables and drinking them is not doing you any harm. And, I do recommend that people think about a variety of ways to get vegetables. It's good to get some raw. I know Dr. Esselstyn, who's, a fantastic person and advocate for health. I participated in one of the conferences recently. I know he talked about liking to steam them and, different theories there, but it's all good. Just eat more vegetables, blend them, steam them, saute them, boil them, frappe them, just get them in. And ideally, the fresher, the better. If you don't have access to a farmer's market, that's okay. If the only place you can get vegetables is a Walmart, that's better than no vegetables. Of course, ideally, farmer's market, all of that. But I just want to say, Stephen, that, most of the useful stuff that I know as a physician that I'm able to share and pass on to other people, I learned from people like you. I learned from patients who were generous enough to share what they were going through and who trusted me to say, well, let's try this and let's try that. And so, this community of people who have suffered similarly and who come together to participate in things like this and to share their experience is just invaluable. So I'm so sorry that you went through all of that, but I'm so grateful that you're here and you're sharing and you're doing better. So thank you.
Thank you so much for that, Doctor. And we're going to move quickly now to Thomas. Welcome, Thomas.
Oh, thank you very much. I always love a doctor who's a true scientist, and I'm going to get one of your books. My question is not so much of a clinical nature, but of a human physiology. Now, we know that cows are able to digest grass because the grass has beta-galactosidic bonds, where the sugar is in the grass, but they can break it down in their cacum. Now, my question to you as a human being, we have appendix, and in our appendix, is there not bacteria that is possible to break down beta-galactosidic bonds? And I suspect maybe the smoothie is breaking down those beta-galactosidic bonds to allow more of the fiber to be digested. Of course, the raw, you have the full fiber. We can't break down those beta-galactosidic bonds for the sugar. Explain that. Is there a purpose? The question, I'll be very brief. I want to be brief. Is there a purpose to the human appendix for that reason? That's it.
Yeah, Thomas, that is such a fantastic question. And really, I can't tell you, like literally not a week goes by where I have a conversation with somebody who, and I assume you're not a doctor, but you may be, but where I have a conversation with somebody who's not a doctor. And I'm like, how is it that you understand these principles better than my medical colleagues? I had this conversation just last night with a friend who called me in dire straits, who had been in the emergency room with some abdominal pain, and they wanted to take out her gallbladder. And she sent me a copy of a CAT scan that was totally normal and labs that were normal. And I was like, do not let them take your gallbladder out. And she said to me, well, because the gallbladder does important things, right? And I said, yes, absolutely. And she said, well, the doctors in the ER told me the gallbladder wasn't important. So Thomas, you hit the nail on the head with the appendix. My surgical colleagues and some of my GI colleagues refer to the appendix as a vestigial organ, meaning, yeah, it once served a purpose, maybe when we were ruminants like cows, but now it doesn't serve a purpose anymore. But we have very clear data that the appendix is a repository for gut bacteria to hang out and to get mobilized when you need them, like in the case of a foodborne infection, and perhaps for breaking down galactosidase bonds, et cetera. So we know that the appendix is not vestigial, just like you need your gallbladder. It's a critical digestive organ, and so is the appendix. And we know that removing these organs can lead to consequences. So for example, we know that appendectomy, the surgical removal of the appendix, is a risk factor for inflammatory bowel disease. And nowadays we're a little bit better, right? Instead of just whipping out somebody's appendix, now we'll often treat through appendicitis. Unfortunately, we're treating through with a lot of antibiotics, but that's still better than removing it. So I'm so glad you asked that question. These are important organs and we need to try and hold on to them.
Thanks very much for that, Doctor. And now we're going to move on to Lynn M. I am asking you to unmute Lynn M. if you're there. Hi, Lynn.
Hi, Doctor. I just have to say your talk was the best talk that I've heard through this whole summit. I have a serious concern. I'm kind of emotional right now. My 11-year-old granddaughter was just diagnosed with Crohn's disease, and I'm trying to find ways to get her back to health. She's kind of a picky eater, but I'm pretty much plant-based and I eat lots of vegetables, and I'm trying to encourage her to do that. And I think after listening to your talk, I need to get her a Vitamix or some kind of high-powered blender and get her on green smoothies. Do you have any advice for me?
I do, Lynn. I do. First of all, thank you so much for your kind words. And what I want to tell you is there is a silver lining to this. I would not wish Crohn's on my worst enemy. However, what I will tell you is that having a chronic autoimmune disease like this at a young age, with a grandmother like you to help guide her, she is going to basically connect the dots between how she lives, what she eats, and how she feels. She's going to connect the dots at a young age that some people don't connect till their 60s when they're lying there after their first heart attack about to kick the bucket. She's going to put it together early. My Crohn's patients are incredible. And again, not a disease I would wish on anybody, but particularly the ones who are diagnosed young, they get it. They are smart. And you know what? They look at food as medicine. They definitely are not live to eat. They're eat to live. Now, this can take a little while to happen, right? She's 11. She's, going to be going to birthday parties and stuff where everybody's having cake and cookies and ice cream, and she's going to want to eat that stuff. And she probably is going to eat that stuff. And I would recommend that when you think about the approach with her, that it's not like, oh, you can never have this stuff, but you want to let her know balance, right? If you eat a lot of this stuff, it's going to change what's going on in your gut, and it's going to make your disease worse. So think about having, a bite of cake and make sure that you're having all the healthy stuff. The Vitamix is such a great idea for her. Get her a little smoothie recipe book, have fun in the kitchen with her where she can play around, and let her put whatever fruit in it she wants it to taste good. When I started doing these with my daughter after her long illnesses, multiple viral and bacterial illnesses from all these antibiotics, we started out with smoothies that were primarily strawberries and bananas with a little bit of coconut yogurt, and I would put some spinach in it. And the spinach doesn't really change the taste much, but it changes the color. So when it was just the strawberries and bananas and the coconut yogurt, it was pink and, like a pretty color in her mind. And then when we put the spinach in, it turned to sort of a muddy brownish color that didn't look quite so nice. So I would put it in a bottle that was opaque, that wasn't see-through. So she didn't pay attention to the color and she would just pay attention to the taste. So it would be so great to have some smoothie parties with your granddaughter where, you play around and like, let's try a little spinach, let's try a little kale, and put in the plant-based yogurt and the fruit so that it's more palatable. And then over time, start to decrease the amount of sweet so that she gets more used to the amount of more bitter. And the same thing with the vegetables, like literally if she's eating 4 green beans with dinner, it's a start. She doesn't have to, become completely at 11, adopt a whole food plant-based diet. It would be great if she did, but just start with, make sure she knows that it's less about what she's eating that's bad and more about the good stuff that she's missing. So focus on, we got to feed our good microbes and, play around with the food. And I tell you, Lynn, when she gets it, and if she's your granddaughter, she's going to get it fast. She is going to be so far ahead of the curve. She's going to be healthier than her peer group because despite the chronic autoimmune disease, and hopefully Crohn's is going to be in her rearview mirror pretty soon. And even if she does need a more potent drug to get it into remission, even that, right? It doesn't mean she has to stay on that forever. So she is going to make that connection and she's going to be healthier than her peer group because she is going to understand food is medicine and what that means and connect those dots. So I'm cheering for her. And I know with you guiding her, she's going to be just fine.
A really, really empowering doctor. Thank you very much for that. And we'll now bring in Sandy. Welcome, Sandy.
Oh, hi. Can you hear me?
Yes.
Oh, great. Hi. I just had to pick up my brother from the hospital who was diagnosed with diverticulitis. So I taped your program. I'm sorry, I didn't hear the whole thing if you touched on it. So I have a question around that. Of course, they gave him blanket antibiotics.
Of course. Yeah.
Well, he was in there for 4 days. And also I want to know if you take patients near Long Island, and I will definitely get your new book.
Thank you. Well, Sandy, your brother was lucky that you were able to go pick him up. I didn't talk much about diverticulitis, but I'm going to give you a quick, 60-second. And I'll tell you, if you go to either Gutbliss or go to digestivecenterforwellness.com and look under health topics and you'll see diverticulosis. And I have a very comprehensive explanation of the difference between diverticulosis and diverticulitis. Diverticulosis is the presence of these potholes in the colon, right? And the stool can lodge in there and it can lead to bowel irregularity, et cetera. And diverticulosis develops only for one reason, and that's because we don't have enough fiber in our diet. So our colon has to push really hard to expel the stool, and that leads to these pouches in the colon. More than 50% of Americans over 50 have diverticulosis, and most people aren't even aware of it. But diverticulosis can become inflamed, and that becomes diverticulitis. So diverticulitis is inflammation of the pockets. Now, like a lot of other inflammatory things, we treat with antibiotics out of a misguided sense of how we should be using them. And sometimes there is actual infection, but a lot of times it's just inflammation. When the diverticulosis becomes itis, when it's inflamed, and that can happen because of constipation, it can happen because of taking too much ibuprofen, it can happen for a number of reasons. When that happens, you typically have to go low fiber. You have to do, kind of almost a clear liquid diet. But the best thing for getting diverticulosis under control and preventing diverticulitis once he's resolved is eating a lot of fiber. A tablespoon of psyllium husk in the morning can work wonders. So I want you to go to digestivecenterforwellness.com. You'll notice we are not selling anything on the site. We don't sell any supplements or anything, just information. Go to health topics, go to diverticulosis, and we have all the information you need for what causes it and what he can do to feel better. And I certainly hope he feels better. And that was so nice of you to pick him up.
Wonderful, wonderful. Thank you for that, sharing that resource as well, doctor, and for having it. Let's go now to Mary. Welcome, Mary.
Hi, thanks so much. This is very interesting. So it sounds like oats to you are good. which I'm very excited to hear that. And also, I've also heard about chewing your vegetables for a certain amount of time, maybe because of the saliva, if you don't chew them for long enough. Do you have an opinion about how much you're supposed to chew?
Yeah, I do. You know, digestion really begins in the mouth. Actually, it begins even before we put the food in our mouth. When we smell an aroma, or if we see a food that we like, our salivary enzymes, our salivary glands start to release enzymes. So we think of enzymes like amylase that break down starch as coming from the pancreas, and the majority of amylase comes from the pancreas, but we also have salivary amylase that gets released. So even before the food gets into our mouth, Mary, the salivary glands release amylase to start the digestive process. So ideally, you want to chew well enough so that that food can start to get broken down and worked on by the digestive enzymes. But, you know, fear not, because if you're a fast eater, as I tend to be, and you're eating quickly and not chewing for a long time, as the food gets down into the stomach and the first part of the small intestine, the duodenum, there's also more amylase, lipase, all these different enzymes, pepsin being released. So, you know, ideally you want to eat nice and slowly and chew your food well, but it will get digested even if that doesn't happen all the time. So you're in good shape.
Excellent. Thank you again for that, Doctor. And up next, we have Dr. Linda. I am asking you to unmute. Let's see if that works.
Hello.
Hi, Dr. Linda. Hi.
Hi, how are you?
Very well, thank you.
All right, so I am 55, African-American female, live in Mississippi. None of these wonderful things you all have been sharing is here. And I have lupus. And so I just really want to cure myself and have a healthy, good quality lifestyle. And I just really don't even know where to begin.
Oh.
And so I just need any guidance or that I can get, or if I can make an appointment and fly up and see you, or you could be my vacation.
That's so sweet of you, Dr. Pendleton. Well, I'll tell you, I actually don't treat lupus because I'm a gastroenterologist, but I can give you some advice. First of all, it's so great that you have decided that you want to heal yourself and you're on this journey. And I want to tell you and other people who are listening, I don't want you to think that conventional drugs are bad and only a food as medicine approach is what you should be doing. There is a role for medication. I am a big advocate for what I call judicious prescribing, meaning let's start with the diet and lifestyle modifications, not just changing your food, thinking about, you know, how much sleep you're getting, thinking about how you're handling stress. Are you getting enough exposure to nature? All the things that we know inform our health. So we start with that. And then you start at the bottom of the pyramid. What's the least toxic medication you can use for your lupus? And then you march up that way, right? We don't stop at the top of the pyramid, like some doctors like to do with the most potent medication. And for some people, all they need is a diet and lifestyle piece, and they're good. Other people may need something, and the disease may change. So your lupus may be really active and you need more potent drugs, and then it may be less active. So I want you to think of an approach that is both, right? So it might be hearing what the conventional doctors have to say about what the drugs are, but at the same time, seeking out a practitioner who is more holistic, who is familiar with lupus. I wish I had a name for you for MS. I have my dear friend, Terry Walls, WAHLS. Her first book was a Walls Protocol, and she is an MS sufferer herself, and she's done incredible work with the MS community. I don't know, you know, for thyroid, it's my friend, Dr. Aviva Ram, who's wonderful, who has a bunch of books. Did Brooke Goldner have lupus? I feel like she did. And I would check, Dr. Pendleton. I'm not positive, but you know, Stephen mentioned Brooke Goldner earlier, and when he said he met, and I told you I met her at the Plant Nutrition Project at a conference in California years ago. And I believe, I'm not 100%, but I believe her story is she had lupus in medical school, I think. So look her up. I know she works virtually with people. And I hope I'm not giving you the wrong name, but look her up. and see, and don't feel like it has to be either or. You know, your conventional doctor could be helpful too. I also believe in full transparency. So I always tell people when they come to see me for a second opinion, I always tell them, look, I want you to tell your doctor, wherever they are, that you came to see me and you're looking at how diet could help with your Crohn's and ulcerative colitis, but you're also open to, I mean, I prescribe when need be. I have a white coat and a prescription pad. I try to whip it out as infrequently as possible, but there are patients who come to see me who are really sick sometimes. And I'm like, look, I think you actually need a big gun medication like a biologic to get your disease under control. And then, you know, while you're doing that, let's work on the food as medicine approach. And hopefully we'll be able to get you off this in a year or in 18 months. But I think right now you need something. So it's not either or, you know, it's really just finding the people who are going to support you on your journey to heal yourself. And I know you're going to succeed.
Thank you, Dr. Chutkan. And I mean, really, thank you. Thank you for being here, for accepting our invitation. Thank you for a very thorough presentation that just, it was so meaningful to all of us. And I think what I really want to say is thank you for coming from your heart. I know that all of us felt that in a very big way. So really, really appreciate it. And the truth is, I am certain I am not the only one that wants to thank you. So hang in there. We're gonna have our tech team unmute our entire audience. Please, everybody, what do you want to say to Dr. Chutkan for this?
To feel so awesome.